right, guys, so now I'm going to be discussing the coronary circulation and how the blood travels throughout the system, not within the chambers of the heart, but I'm going to be discussing or differentiating between arterial and venous perfusion, as well as the coronary artery circulation. So to start off, guys, let's discuss the major anatomical structures of the outer surface of the heart. We have the pericardial sac. It's a serous membrane that surrounds the heart, and it's got two layers to it. One of them is known as the parietal pericardial sac, and the other one's known as the visceral. And in between those two layers, you have serous fluid. So if you can imagine a sac that envelops the entire heart, and there's two layers to it. The layer that's actually touching the heart, the one that's closest to it, it's known as the visceral layer. Okay, so this is the visceral. It pertains to organ, and the heart's the organ, viscera. And then the layer of the pericardial sac that's touching, let's say, the structures that are surrounding the heart, which would be the lungs, that layer right here, the outside part, that's going to be known as the parietal. The whole purpose of the pericardial sac is to provide lubrication as the lungs expand and squeeze onto the heart, and as the heart contracts, with the pericardial sac being filled with serous fluid, and the pleura of the lungs, which is analogous to this, except it's for the lungs, it's called the pleura. Both provide lubrication. There's not going to be much friction, and the lungs can expand continuously without any issues, as the heart can contract continuously without any issues of friction and things like that. So that sac surrounds the entire heart. Then we talk about the layers of the actual heart muscle. The inside is known as the endocardium. The middle portion of the heart muscle is known as the myocardium, and that's the actual pump of the heart. Okay, that's where the coronary arteries are embedding deep into so they can perfuse, oxygenate the cardiomyocytes, the heart cells. And then you have the outside portion of the heart, not the pericardial sac, but what we call the epicardium. Please make note that sometimes they discuss the epicardium and the pericardium as being the same thing. They're technically not. The epicardium is just the outside of the heart. The pericardial sac is the actual sac that envelops the heart, which provides that lubrication that we discussed. So every time the coronary arteries are sending adequate amount of blood to the myocardium, to the heart, to the pump of the heart, then the heart will actually pump adequately. Your cardiac output, your stroke volume, all of that will be sufficient. However, there are some circumstances where you're going to have limited oxygenation to the tissue. What I'm talking about is the word ischemia. So the word ischemia is talking about a deprivation of oxygen to the tissues. And so when the patient does develop ischemia, that's where we start developing chest pain. And the technical term for chest pain is going to be known as angina. So ischemia leads to angina, and some people say angina, depends how fancy you want to get with it. So you can say angina if you want, okay? I, generally speaking, refer to it as angina. This is caused by temporary deprivation of oxygen to the myocardium. We call that ischemia. And so now let's talk about what causes this ischemia. Well, we have all these coronary arteries. We have two main branches that come off the base of the aorta as it leaves the left ventricle. And so if I draw a little illustration right here of the blood vessel wall, let's pretend this is the coronary artery. Inside the coronary artery, all them cheeseburgers that we consume, all them tacos and pupusas are gonna contribute to something that we know as atherosclerosis. And atherosclerosis is a plaque buildup that you develop inside the lumen, the space, the wall, of the blood vessel. And so what it ends up doing is you develop this plaque, this yellow plaque. And the plaque decreases the blood flow of the heart, or it decreases the perfusion to the myocardium, to the heart cells. And this is what contributes to cardiac ischemia. It leads to angina. It's this atherosclerosis, the plaque buildup. Then you develop the hardening of those blood vessels, and that's known as arteriosclerosis. Some people refer to both of those terms as being synonymous with one another. Technically, they're just very much so related. Atherosclerosis is the plaque buildup. Arteriosclerosis is the hardening of that blood vessel caused by the cholesterol developing inside of those blood vessels. Let's take a moment real quick to discuss those two different things. We've all discussed fat, fat, adipose tissue, right? When we discuss cholesterol, you need to understand that we have two basic types, okay? You have the good cholesterol, the good fat, and the bad fat. You've seen all those memes of the avocado chasing the wife avocado saying, I said you were the good fat, okay? We're talking about good fat and bad fat. In this particular case, we're gonna discuss the word density. Density means how hard or how soft something is. The more dense it is, the more hard it is. So if we pretend that we have a little ball, a globule of fat, and I throw it against this wall right here, if the globule of fat is highly dense, if it's very hard, it's gonna bounce right off the wall. That's what we call our high density lipoproteins, or HDLs. And those are actually beneficial for us. That's the type of fat that we gather from avocados, usually plant-based foods. And some books suggest salmon as well, the oil fats, right? So these are high density lipoproteins that are attached to proteins, and the organ that's responsible for the contribution of developing that or synthesizing that is going to be your liver. And then we have the bad cholesterol. The bad cholesterol are known as low density lipoproteins, LDLs. And your low density lipoproteins means that the globule of fat is squishy. It's not hard, it's got low density. So when we throw it against the wall, the blood vessel wall, it sticks to it as opposed to bouncing off like your high density lipoprotein. So I hope that clarifies the difference between your high density good cholesterol and your low density, the squishy part that contributes to atherosclerosis. When the patient has a diet that's unfavorable, that consists of high triglycerides, high fried foods, hydrogenized foods, we're talking about foods that contain low density lipoproteins. Think of when you're cooking some food on your sartén, on your I can't even say it right now, I don't know what's it called, but on the stove, and let's say you're cooking some carne asada. When you're cooking it, the grease falls off the meat, it gets oily, it gets liquefied. But once the heat is turned off and then it's sitting there for quite some time, the fat solidifies. That's what I mean by low density lipoproteins. In room temperature, low density lipoproteins, they become hard. Well, not hard, but they become solid. And that's what happens inside of our bloodstream. They become relatively hardened, and it starts developing, it starts contributing to atherosclerosis, okay? Generally speaking, when we talk about high density lipoproteins, we're discussing the ones that are watery at room temperature. So they're highly dense and they bounce right off the wall. We don't have to worry about them actually sticking to it. They do not contribute to atherosclerosis. And in many cases, it's proven that the high density lipoproteins knock off some of that atherosclerotic plaque, okay? This condition, atherosclerosis, is what at times contributes to ischemia, angina. And when the patient has angina pectoris, angina pectoralis, which is chest pain, the whole goal is to vasodilate. We must vasodilate. We must open up that blood vessel in the coronary artery because we must maintain patency so the myocardium can become perfused. So we start discussing what types of medications can we give to open up those centralized veins on the surface of the heart, the coronary arteries. What we're gonna do is we're gonna give nitroglycerin. Nitrates are primarily found in foods that are plant-based. Nitrates are good because they open up those blood vessels. I believe the most current event that we had, I think it was in, I forget what country it was in. I don't want to misquote the country, but they had a bunch of nitroglycerin in that building and they caught the explosion on camera and it went, it exploded, right? So that's what nitroglycerin does. Nitroglycerin is used for explosives as well as to vasodilate. So when you guys start thinking about medications, we have atherosclerosis, you have to follow the concept. You have a diet that's high in low density lipoproteins, fat that's going to deposit in your blood vessels and cause atherosclerosis. Well, how do we immediately relieve the ischemia? Well, we have to vasodilate, and we do so by giving the patient nitroglycerin. We give it sublingually. We can give it in 5-minute increments. And if by the third time the patient is still having chest pain, we call 911. This is an actual potential myocardial infarction, which we'll get to in just a bit. When we talk about nitroglycerin, I want you guys to remember the whole explosion. I think it was in Beirut. I hope I'm not wrong with this one. The explosion occurred, right? Well, when somebody places the nitroglycerin little tablets underneath the tongue, they're gonna feel a little bit of tingling sensation, and that's expected. It's good. That means that the medication is still potent and it has not expired yet, okay? It's important to get the nitroglycerin and to store it away from the sun in a cool location, because the sunlight and the heat break down the metabolites of the drugs, and you have to reorder the prescription every 3 months to ensure that the medication is still potent. So keep in mind that that little tingling sensation that the patient will report when you put the tab underneath the tongue is actually a positive thing. That means that the medication is still working and it has not expired yet. So if we're thinking about vasodilation, you have to think about blood pressure. What happens to the blood pressure when the blood vessels, when they dilate? Well, to answer that question, get your hand and place it on the surface of your arm. If your hand represents blood vessels and they constrict, they squeeze your hand, the pressure is increasing. But if the blood vessels dilate, the pressure is decreasing. And this is what happens when you give somebody nitroglycerin. You give them nitroglycerin, it's gonna open up those blood vessels, the blood pressure is gonna drop. The patient may develop a headache, they may get a little bit dizzy, they may have a syncopal episode. So it is important that we position our patient accordingly. You wanna make sure that you at the very least sit them down. Lay them down flat if you can, because you understand that the blood pressure will be dropping. So the concept is nitroglycerin, powerful vasodilator. Vasodilation causes hypotension. Now the patient is at risk for injury in case they have a syncopal episode because of the low blood pressure. So ensure that they're in the proper position so they don't develop an injury in case they do pass out. Continuing the talk with the coronary artery supply, we have to discuss the oxygen demand. And the oxygen demand is just a fancy phrase to describe how much oxygen the myocardium needs. If I become physically active, my myocardium is going to be pumping a lot more efficiently. It's going to have to pump a lot harder to maintain the oxygen demand, right? So you have to keep in mind that we have to decrease the oxygen demand when somebody has ischemia. And you do that by having the patient sit down and stop moving. So when it comes to interventions, for somebody who's suffering from angina, from myocardial ischemia, the initial intervention would be to have them sit down, to decrease the oxygen demand, to decrease the physical activity, because that's what's going to allow the patient to have the blood supply available for other things versus the ischemic heart. The ischemic heart needs that oxygen, so we want to decrease the physical activity. So the cardiac demand is decreased and the heart can now function better with the less amount of oxygen that it's going to be needing when they're sitting down, opposed to as becoming physically active. When somebody is suffering from ischemia, from myocardial ischemia, they develop angina, we discussed that you give it once, you wait 5 minutes. The patient still has chest pain, you can give it again. You wait another 5 minutes in between, you assess the patient. If they still have chest pain, you give it a third time. If after those 5 minutes they still have chest pain, we treat it as a heart attack. But if it goes away, then that means that it was angina and that we took care of the issue. Let's discuss what happens when somebody's pain, the chest pain, does not go away and they continue to have angina after the third administration of nitroglycerin. Generally speaking, when the pain continues and it persists, it means that the myocardium is suffering from not only ischemia now, but it's perhaps going to start developing what we call necrosis. And necrosis is the death of the heart tissue. And at this point, we have to call 911, we have to treat it with morphine to decrease the oxygen demand, oxygen to maximize oxygenation of the myocardium, nitrates, nitroglycerin, to open up those blood vessels, and then we give aspirin prophylactically. Now, that's your job, right? But there's only there's a limitation that the nurse can carry out when it comes to a heart attack. So let's discuss about the medical interventions that you're probably going to be partaking in regards to the pre and post procedure assessments. So let's discuss briefly cardiac catheterization. And I want to focus on this illustration up here because cardiac catheterization occurs when somebody gets a catheter placed usually in the femoral artery or in the brachial artery, and the doctor inserts a catheter that goes through the femoral artery, up through the abdominal artery, into the thoracic aorta, the aortic loop, and then it makes its way inside the coronary arteries. And what the doctor will do is that they'll inject the contrast medium, and we can take a diagnostic image and we can find out to what degree of atherosclerosis the patient's suffering from. So, cardiac catheterization. Our role, our job as a nurse, is to be able to provide the pre-procedure assessment. So, your pre-procedure assessment primarily deals with the assessment of the neurovascular status. When I say the neurovascular status, I want to make sure that if the doctor put a catheter right here in the femoral artery, we know that we're bypassing the blood vessel wall, the arterial wall in the femoral artery. And at that point, circulation becomes a potential issue. The liability is that the patient might bleed out. And since we're putting that catheter inside a highly pressurized blood vessel, we have to have assessment parameters so we can tell if the patient's bleeding out, to see if that artery, if the doctor went all the way through, and perhaps they're going to be bleeding internally. So we have to set our foundation. Before they do the procedure, you explain to the patient what's going to happen. The catheter goes into the femoral artery or the brachial artery, but usually we do the femoral artery because the brachial artery, we need our upper arms for more practical things, so we tend to do it mostly in the femoral artery, but in some circumstances we do utilize the brachial artery. The catheter will go inside, it'll go through the abdominal aorta, thoracic aorta, through the aortic arch this way, and then it will go inside either of the coronary arteries. There will be contrast medium injected. Please keep in mind that the kidneys must clear out the contrast medium. And if the patient's diabetic and they're taking metformin, which is a type 2 diabetic medication, well, if both of those chemicals are inside the circulatory system at the same time, once they both pass through the kidneys, they will cause acute renal failure. So make sure you guys educate the patient to hold metformin 48 hours before and 48 hours after the day of the procedure when the contrast medium will be injected. Doesn't matter what the procedure is. If there's contrast medium that's going to be utilized, then you must make sure you educate the patient to hold metformin for 48 days before and then 48 days after, to make sure that we utilize those 48 days prior and after the procedure for the kidneys to excrete the metabolites of metformin, so when they inject the contrast medium, both will not be in the system and thus cause acute renal failure. The patient will also be educated that once that catheter goes inside the heart, well, the heart has a reaction. It's got muscles that react, it's got excitability, so the patient might feel a little fluttering sensation. You must educate the patient that that is expected. A little palpitation, a little fluttery sensation is expected when the catheter enters the chambers of the heart, the superior vena cava, and therefore afterwards the coronary arteries. What you want to also educate the patient on is that when they inject that contrast medium, it becomes part of the systemic circulation. They may feel a little metallic taste, and that's also expected. The procedure will go and will be carried out. The doctor will make their decision as to whether they're going to do coronary angioplasty or not. What that means is that we can fix the issue of atherosclerosis within the coronary arteries. We could do something called balloon angioplasty. And we can do balloon angioplasty in the way that the catheter goes in, has a balloon attached to it, it inflates and it pushes all of that plaque against the arterial wall. And what it does is it provides a temporary but pretty efficient means of maintaining patency of that blood vessel. So when that balloon angioplasty is carried out, the balloon inflates, it pushes the atherosclerotic debris or the plaque against the endothelium of the blood vessel, and thus promoting patency. And patency is opening. In some instances, they may do balloon angioplasty with stent placement. And a stent is a little device that's left inside that keeps the patency of the blood vessel wall. And it looks something like this. The device is outside. I'm sorry, not outside, it's inside. And it's got like a little fence thing that keeps it patent, that keeps it open. The only issue is that now that you have a foreign element inside the coronary artery, this patient will now have to be on medications for the rest of their lives essentially, because they're going to be at high risk of clotting, so we're probably going to put them on Coumadin. So keep in mind, cardiac catheterization, you're responsible for the assessment, the neurovascular assessment. And how do we assess that? We do CMS. Circulation, motion, and sensation. Keep in mind that circulation, motion, and sensation are done by assessing the capillary refill of the feet, of the distal extremity that's going to be that the femoral artery, that the catheter is going to be accessing on. You do the motion by, you ask the patient, can you wiggle your feet, can you wiggle your toes? And you stroke the side of the foot or any part of the foot and determine whether the patient has sensation. If all of those three things are intact, if the capillary refill is less than 3 seconds, if the dorsal pedal pulse is intact, if the foot is warm, all of that is assessing circulation. If the patient has movement to that lower extremity, then that element is also met, and then the sensation, the nerves are also intact. These three elements encompass your neurovascular status, and that is your platform. The procedure is carried out. You ensure that the patient held the metformin before and after for 48 hours, if that's what they were taking. And then once the patient comes back, now you have to do your post-procedure assessment. You assess the very same thing, but you're doing it afterwards. Post-procedure assessment. You want to ensure that while the doctor was carrying out the procedure, they didn't pass all the way through and they did not cause some severe bleeding. So you assess circulation, motion, and sensation all over again, and you compare it to your pre-procedural assessment, ensuring that they match. If there's a deficiency, if the dorsal pedal pulse was strong before the procedure, but now it's weak or absent, you report it. If the capillary refill was 2 seconds before the procedure, and now it's 4 seconds, you report it. If the patient had sensation and movement before the procedure, and afterwards they have limitations on either of those, you report it. That lets us know that there's a deficit, and such things like complications of bleeding may occur, so you must report it. Patients who undergo cardiac catheterization must be educated on their positioning after the procedure. Keep in mind that you must keep the head of the bed lowered, because imagine I'm flat supine. If I keep my head elevated, what I'm doing is I'm flexing at the hips. And when you're bending that location, you're bending the blood vessel and it won't clot. I'm not talking about DVT clot. I'm talking about the blood vessel wall. It needs to heal. So you keep that head of the bed at its lowest position as possible. The book says no more than 30 degrees. At the same time, you must keep the legs straight for several hours, 4 to 8 hours, and the patient may be placed on bed rest for up to 12 hours to allow the access site to heal completely, to clot, so the blood vessel wall will stop bleeding. And you must apply pressure. Sometimes they'll even place some pressure dressings with sandbags on top to ensure pressure and positioning. Okay, so those are the elements that you as a nurse must focus on when it comes to cardiac catheterization. Moving on, we also have to discuss what ends up happening when we have peripheral issues, peripheral vascular issues. Right now we discussed the elements that dealt with the coronary arteries, and that's known as coronary artery disease, CAD. Atherosclerosis, limitations in perfusion. We discussed angina and the chest pain and how to medically intervene. But now let's discuss what happens when you have issues in the peripheral circulation, issues in the arteries of the arms, of the legs. To start off, the concept should stay consistent. The abnormal plaque buildup is what contributes to the atherosclerosis. So we're talking about poor diet choices, lack of exercise, because exercise promotes what we call collateral circulation. And collateral circulation is really important because the more you exercise, the more blood vessels you're creating, and that's what collateral circulation is. When people exercise, their bodies create new blood vessel supplies, then they tend to perfuse the systems a lot more efficiently. But when those blood vessels become compromised, when you develop atherosclerosis, you have to keep in mind that the concept's the same. The blood vessel lumen is no longer patent. There is an issue with the perfusion. There's going to be ischemia. When ischemia develops in the lower extremities, we call that intermittent claudication. And intermittent claudication is a terminology that we use to describe when the calf muscles, which are represented by these little lines right here, develop some degree of ischemia because of the lack of arterial circulation. And because of that, we have to make sure that we promote circulation by positioning that extremity adequate. So you have to think, what is the whole purpose of the arterial circulation? Where do arteries send blood to? And if you guys pay attention to the arrows that are included in this little diagram right here that I so eloquently drew up there for you guys, the arteries always pump blood away from the heart. So when we talk about arterial circulation to the calf muscles, intermittent claudication, the lack of, then we have to position the extremity in such a way that it will promote perfusion to the tissue. So do you elevate or do you lower the leg? What you want to do is you want to lower the leg. The reason why you want to lower it is because if you want to promote blood perfusion towards the distal part of the foot, you elevating is going to contradict or counteract the effects or the desired blood passageway of the arteries. So you place them in a dependent position. You place the legs in a dependent position to improve intermittent claudication. One of the things that we also have to keep in mind is that the concept's always the same. The patient that we were discussing earlier that had angina caused by myocardial ischemia, we wanted to decrease the oxygen demand, right? Well, if you decrease the oxygen demand, meaning that you have less physical activity, so you stop the demand for oxygen. Well, the same thing goes with this patient. If we ask this patient to sit down and stop moving to decrease the oxygen demand, well, the same thing's gonna happen with your patient that has peripheral vascular disease, intermittent claudications. You will have the patient stop their physical activity. If they verbalize to you that they're having ischemia while they're climbing up some stairs, while they're walking, then you have them sit down and stop carrying out that movement because that therefore decreases the oxygen demand. It's important that we keep that in mind, guys, and we can give peripheral vasodilators such as ACE inhibitors, beta blockers, calcium channel blockers to ensure that the blood vessels open up more so they can have better perfusion. Let's switch gears now and discuss your venous supply. A lot of patients, when they have peripheral artery disease or peripheral vascular issues in general, can develop venous insufficiencies. Now, we have to discuss, well, if the arteries perfuse blood away from the heart, well then in the veins, outlined by these black little lines right here, well they must take blood back to the heart. And that's essentially what happens. Your veins are supposed to send blood back to the heart. And it has to pass through the liver via the hepatic portal vein, and then through the hepatic vein to the inferior vena cava. We discussed this in right-sided heart failure. But keep in mind that your venous circulation, the whole purpose is for it to send blood towards the heart. So, if the patient has some venous insufficiency, what are we going to notice? Well, it's important to note this illustration right here. The red muscles right here, these represent the calves. The black vessel in between the little one-way valves, those represent the veins. In order for venous blood to return back to the heart, we must have muscle contractions. This is why it's so important to ambulate your patient after any particular surgery, because during the surgery, if they had general anesthesia, they've been in bed, they haven't been moving that much, they develop venous stasis. And when you develop venous stasis, you may develop excessive coagulations, DVT, and that's what you want to prevent. That's why the goal is to ambulate your patient as early as possible, assuming that it's allowed based on their condition, so we can promote muscle contractions. And when the muscles contract, they squeeze that vein and they push blood back to the heart, which promotes venous return. So when somebody has venous insufficiency, the whole goal is to this time elevate the extremities, because elevation of the extremities promote gravity to push the blood back up towards the heart. So keep in mind, guys, you have to understand the foundation. The foundation of our arterial circulation is that the arteries move blood away from the heart. So for us to get it to those tissues, if we're talking about the lower extremities, we must place them in a dependent position, below the level of the heart. But if somebody has venous insufficiency, veins are supposed to take blood back to the heart, then we elevate the extremities to promote venous return.